So hello and thank you for joining and embarking with me on my trip to show you the no sinus lift concept, which is my daily DNA and the DNA of my daily business and my daily practice. What my goal was with setting up that concept was to reduce invasiveness and complexity to get a better patient journey with less trauma, less pain, and getting more patients, more success, and more happy patients referring more patients. The sinus lift by itself is a concept which is well established. Let me point it out. It's a concept which we need. We need to sinus lift. The question is how much we need to sinus lift. It was established a long time ago, much longer than most of us think, in the late 70s by Tatum and Misch. And if you do a Google search about sinus lifting, you will find over 2 million sinus lift points. But again, on the other hand, sinus lifting, it's easier said than done, and so many people do it, and we see so many complications being referred for treatment. It's, in the end of the day, a big flap, opening up a big bony wound, a bony window to the sinus, inserting different types of autogenous or heterologous materials to restore the bone which was lost by atrophy. Easier said than done, because we see like a third of the sinus lifts performed experiencing complications. It's a very emotional topic, sinus lifting, because in certain parts of the world, sinus lift has become a business concept. Dentists, surgeons receiving patients for sinus lifting, for implants, and referring them back, sending them back to the original doctor. So if sinus lift is your business concept, I fully understand that you feel attacked, but you shouldn't, because this is for the benefit of the patient and of the benefit also of our practices. The sinus lift by itself is well established. We need it and we do it on a daily basis. The only thing we do is we understood and had to accept that it's way too often performed, and those cases which are avoidable, which in my eyes is 70 to 80% of the sinus lifts done today, should be avoided in our common interest. Because in the end of the day, sinus lift is posing a significant risk of complications of different types. If you go onto the internet and you look up sinus lift on Google and on YouTube, you hardly find the procedure first and explanations. What you find is complications, bloody pictures, infections, implant loss, suffering stories of patients. So if you're a patient who has been told you need a sinus lift, I fully understand that you might be a little bit afraid of that, and you are going to ask questions because you are entitled to ask if you can avoid, if there is a way to, a workaround not to sinus lift. Two different approaches here. If you see that first case I want to share with you, I'm going to get back to that case in detail later on in my lecture, then there is quite some bone missing here, but still a mobile tooth with the crown which is going to be lost. And there is some bone in the tuberosity. Of course, the conventional way would be to do a sinus lift, place 2 or 3 implants. You can do that. Nothing wrong you did. But look at the new option, placing the implants right away. Place a long implant, maybe a narrow one. Place a short implant where there's limited bone. And place a tilted implant in the tuberosity. The overall implant surface in the bone, the length, the diameter, is so huge that in cases like this, I'm more than 100% positive that we do not need to sinus lift at all. But again, whatever you go for and whatever works in your hands will be the good solution for your patients. There is vast evidence out there for what we are doing. We see people publishing over the last decades well-esteemed and accepted researchers about short implants, about tilted implants. We have consensus papers. We see the long-term performance of implants placed in the tuberosity, splinted implants. So if we add that together, and please feel free to scan the QR codes here and to look up the full paper which is going to open on your screens, then you will see that that's not like, implant cowboy, daredevil thing. We are throwing away the established protocol of sinus lifting. No, we are standing on solid ground here on well-established evidence-based data with the short implants, the splinting, the tilted implants, the use of the tuberosity bone. So we are just utilizing technologies which are evidence-based and which are here to serve our purpose. If you look into specific papers with this one by Swiss group, Hämmerle, Jung, and et al., then you will see that short implants in the sinus lift have a very similar survival rate as long implants without. So what we see is that the success rates are comparable, but the rate of complications, they deviate. If you can manage to avoid the sinus lift, you serve the patient much better. 3 times the complications with sinus lift than without. Most sinus lifts, and I'm absolutely convinced of what I'm saying, can be avoided. Not all of them. I'm not attacking the technique, the technology per se, but most of them can be avoided. If you tell 10 new patients, just picture 10 new patients coming into your practice, and you tell 10 patients, you need a sinus lift. I think that maximum 2 to 3 patients will say, yeah, I agree, let's go for it. Can I have an appointment? I want a sinus lift. But if you tell the same thing to the same patients in a different way, like, no, actually, in contrary to what you have been told by maybe different specialists or doctors, I can do it without a sinus lift. We can have a way to work around that. Then what I've experienced is that up to 7 to 9 out of 10 patients say, oh, really? I can get the implants without that risky, invasive protocol of sinus lifting. It's faster, it's cheaper, it takes out 90% of my fear. Let's go for it. So even in the conversion rate, in the rate of getting a yes from your patients, your success rate of your consultation, it makes sense. And it's not based on, do one, see one, teach one. I've been doing it for over 20 years. I've been doing virtually thousands of cases with this concept, and with the tilted implants, the splinting of the short implants, the narrow ones, and patients are happy. Patients come back. I see them at the oral hygienic sessions. I see them when they see the dental hygienist, and I always ask them, how long ago was it we placed those implants? And they say, oh, it's 10 years, 12 years, 17 years, 21 years. And that's what's the proof of the protocol, and that's the solid ground we stand on. So what are the key factors? First of all, in most of the cases, we will need a tuberosity. Then we need to place tilted implants there. We combine them with short implants. We need to make sure we get sufficient primary stability. And then we need to master the art of immediate implantation, because with immediate implantation, we make it happen fast and we spare the patient grafting protocols. This was one of the very, very first cases treated with BLX. It's over 4 years ago now. And those patients, which were among the first 3-4 patients ever treated with that, already had the first immediate with BLX, and on both sides bilateral, that patient got already the no sinus lift concept. If you look at the x-ray, you would feel tempted to say, oh, sinus lift, bilateral on both sides, and then place the implants. Actually, no. With today's modern implants, which give you good primary stability, and a huge modern implant surface, I am sure that in many, many cases, if we really ask ourselves, can I do it without a sinus lift? More often than not, you will tell yourself, yes, I can. We can do it without. We have to re-evaluate all the indications. How much sinus lifting do we really need? How much do we have to do? What can we avoid? And when do I have to sinus lift? In those cases, we go strict according to protocol. We sinus lift, we let it heal, we let it transform into bone, and then we do the implant placement. But more often than not, this is what we do. We place the implants, we combine the narrow implants in the mesial with the tilted in the posterior, and then this is how we do it. This is the BLX marching into the bone. You can see and virtually feel, looking at the video, at the movie, you can feel how it grips and the primary stability we are getting here. And then the surgical sequence, placing of the implant, the suturing with a continuous interlocking suture, healing abutments, after the healing and the restoration. We go always screw retained with angulated screw channels if needed. We do not cement anymore, and then it's closed. It has only advantages. It's retrievable, it's clean, it's nice, no cementitis, clean surfaces, clean connections. This is modern prosthetics or modern implantology. Long-term success, many, many years to go. Or a case like this, bilateral maxilla. Here we can save the teeth in the front, but at the first sight we would assume, oh, there is not enough bone left at the laterals. So if there is not enough bone left, still it's enough for this. A long and narrow one, a shorter one, and then angulated. That patient was treated on both sides in the same treatment, and the surgical time was less than 12 to 13 minutes per side. Then we let it heal. In this case, there was no immediate loading and restored. Patient happy ever after, minimal trauma, coming back every 3 to 4 months to see the dental hygienist, and then we see the patient, we reassess, we recall, and we follow our cases. Hashtag no sinus lift concept. This is a case I've been treating over 20 years ago. I was a young surgeon, and that old gentleman got a sinus lift. He got a block graft, and today I wouldn't do that anymore. It was very traumatic. Worked fine, but still today I would do it like this. Maybe a slightly longer and narrow one at the most mesial site, a short one behind that as the central implant, and then tilted. Like this. Works fine, fast surgery. Patients like this refer patients like this, because people have lost their teeth in the lateral maxilla for years and they are reluctant to get treatment because they go from dentist to dentist. This is a doctor shopping, and they are waiting for somebody to tell them we can do it without bone transplantation, without the graft. Finally, they are here. They get it without the grafting, and they are overwhelmed by that. They are more than happy to go for that. They are more than happy to get that treatment done. It's cheaper, it's safer, it's less traumatic, less pain, less treatment time. So which approach would you choose for your mother? If that case is your mom, would you tell her, I'm going to put the bone graft into your sinus? Would you put her to that risk if she is not obliged to do that? If you have a chance, an evidence-based chance, a good probability to work around that, I wouldn't do that. And again, I know that I have said that before, but I'm fighting the thought which is coming up in your minds now that that guy is fighting sinus lifting. That guy wants to tell us that the earth is not flat. No, the earth is not flat. We need sinus lifting. I do not want to abolish it. I need sinus lifting, but I need it much less than I did in the past. In the past, we did iliac block grafts, hip grafts. We harvested bone from everywhere just to do the sinus lift. And you know those cases, harvesting bone from the skull, from the tibia, from everywhere. And I think that those techniques are obsolete, those super traumatic techniques. And I think that we have to look at every case, at every patient individually. Do I really have to sinus lift here? If the answer is yes, go for it. If the answer is no, challenge yourself. Maybe there is a new chapter in your implant life coming up. To again underline how we mean to stick to established technology and surgical techniques, look at this case. Patient already came without teeth in the upper right. No bone, absolutely no bone. So that patient got a sinus lift. He was sinus lifted. And then the patient lost the teeth on the contralateral too. So the same patient who got a sinus lift on the right side with 2 implants and a bridge got no sinus lift on the left side, because we do not only evaluate case by case and patient by patient, we evaluate site by site. So this patient is the typical example to show that one patient, 2 approaches. Does he need a sinus lift on the right side? Yes, he did. He got one. Can I avoid a sinus lift on the left side? Yes, we could. So there was no sinus lift. Same result, less costs, less pain, much faster. So if you can choose what you want to do for your mom, faites vos jeux. So what are the criteria for that? The criteria are what's best for my patient, what would I want to have done to myself or to my next of kin. And then we have to determine when it's a must and when we can avoid it. The decisive factor, the key factor is anatomy, always. You cannot put an implant into nothing. That's why we need to have a certain amount of bone, a certain anatomical configuration of bone. Cases like this, which have no tuberosity, are quite hard to do them without the sinus lifting. So the tuberosity is one of the key factors. No tuberosity, it's getting more difficult. And then again, the tuberosity, as said before, as pointed out, makes the difference. A long way in to go in the bone. This is a 4.0 millimeter diameter implant, which is 14 long, and this is a strong implant, and it will provide support maybe for the rest of the life, maybe for decades to go. Cases like this, I call them the conversion cases. People coming in, they still have a lot of teeth, but we know at the first sight we are losing the teeth. And again, associated with that is an impressive amount of bone loss already due to the gingivitis, due to periodontitis, due to many, many years of whatever factors contributed to the loss of a significant amount of bone. Did we lose too much bone, or is there still enough to have a workaround? There was more than enough for that. These were all immediate implants placed at the second visit. Teeth were taken out. The tuberosity makes the difference. And then again, the choice of the right implant. Now rest assured that whatever implant you use, which works in your hands, is the good implant for you. But ask yourself if with a new implant, you could not expand your range of treatment, your predictability, and the types and numbers of surgery you could do. A new implant, which is more up-to-date, more state-of-the-art, which gets you a better primary stability. There is no such thing as too good primary stability, where you have more choices. These implants which were used here, the BLX, they come as a 3.5, 375, 4, 455, 556, 65. So I do not have to settle for an in-between diameter. I have the implant available which I need. I have prosthetic precision, easy handling, scientific support for the surface, scientific support, logistic support. So this is the reason why my strategy is to always use the most modern concepts, the best concepts with the best products available. I want never to tell to myself, would you have used a better material? You wouldn't have run into that problems. Or asking myself, it could be better if. I hate those ifs. At a certain given time, I always want to provide the best therapy for my patients with the best strategy. So the strategy, the principles are that the local, natural, original bone of a human being is always better than any grafted bone. Choose the right implant which serves your needs the best, which gives you the best stability. Combine short implants and tilted tuberosity implants, even with narrow implants. And then there is two branches here. One is when still those teeth which are doomed to be lost are in the mouth. But then again, with immediate implantation, you can prevent atrophy and prevent the further need for augmentation. If augmentation is already needed, ask yourself if you can avoid to augment by modern concepts. And then again, if atrophy already happened, then maybe with a new out-of-the-box thinking, again, I'm repeating my mantra, short implants, tilted implants, narrow implants, you can handle that and you can manage the atrophy without having the need to graft. And then you serve your patients well. I see recently, the last few months, that my cases which I show on social media, on Instagram mainly, are reposted by big repost sites which show cases to implantologists, to dentists, which have hundreds of thousands of followers. And I really enjoy the interaction which happens there. So cases like this, where at the first sight we would think there is no bone. But I feel that you already get a new way of thinking watching my webinar, which again, I say thank you at this moment. Now you say, oh, like 20 minutes ago, I would have thought there is no bone. Now looking at the picture, the bone looks good. I mean, keep looking at the picture, it will get looking even better. And this is what we did in the end, on both sides. Clean and nice, 3 implants per side, and screw restored. Nice gingiva, Nice prosthetics, again, always screwed. So the before picture and the post-operative after restoration. These are the 2 or 3 implants per side, screw retained, implant bridges fixed, no grafting, very fast surgery. Or another example, 87-year-old lady who 1 week after the implantation had totally unexpectedly to start chemotherapy. So I was really happy, you know, with all those immunosuppressants, with all the medication, the chemotherapy, the radiation she had to take, that there was no grafting involved, that the risk of infection was less. So make it simpler, take out the risk of complication, and you serve your patients better. She said, you know, that bridge, I had it for like 25 years. It broke. She came with the bridge in her hands. And very simple. I mean, 87-year-old, very tiny little, delicate, fine person. And she said, I'm so afraid of bone augmentation. Can you do it without? But I need something to bite. So the teeth were removed. You can see already the apical infection here, the cyst growing, 2 implants placed. This is a less than 10-minute surgery. You let it heal. At this time, she came back after chemotherapy, after a long time, quite some months. She was restored, beautiful healing, and I strongly doubt that the bone, with all the chemotherapy going on and the radiation, the grafted bone would have served this well. So I'm happy that I used the no sinus lift concept for her, and she was happy too. Or another one more. The case you saw in the initial overview. Take out the mobile tooth, which was already restored with an old crown. Look at the bone. And then again, here comes the implant. This is the immediate implant at the premolar site. Stops, and then the manual hand wrench. Look at the torque which we achieve with the immediate implant. It's over 80 newtons. I love it. Then the short implant, which is one of the pillars of the whole concept, which is the central, the mesial implant here. Also with the primary stability, look at how strong it engages the short implant in the middle. And then comes the boss himself, which is the main pillar, the tilted implant in the tuberosity. Tuberosity always softer than the rest. Still, with the treatment protocols which we use, massive under preparations. We drill the whole length, but we don't drill the whole width. This is what you're getting. Why would you want to sinus lift? Why would you want to use a foreign bone material for a case like this, for a patient like this? No need to do that. This is the surgical sequence, and then the prosthetic restoration by the referring doctor. Happy ever after. This case was published by us, so in German and in English, in the European Dental Implant Journal, or the BDIZ Dental Journal in Germany. If you want to read the whole case, the case study, the scientific basis on that, I'm sure you can download the paper if you want it. And I'm happy to co-author the patient with my friend, Dr. Christian Jarre. One more. Again, this case was reposted by the 4 biggest Instagram sites, by Dental Mentor, by Dentistry 911, by Dental Team, Implant Team. And there was a reason for that. Looking at that case at the first sight was like, oh my God, so many infections. Let's assess it. There is the left upper, there is the right lower. Fractured tooth, deep pockets, mobile teeth, pus coming out. So you wouldn't think about immediate implants here at the first sight, but why not if you're following the protocol? Look at what was done. I placed the implants gently and precisely. Nice healing, prosthetic restoration. Again, classic protocol, no sinus lift concept. And I analyzed all these implants post-operatively regarding their position. This was the immediate implant in the mesial at the first premolar. That's the short implant, the 6mm implant in the central, placed at the top, utilizing the bone which was there all the way, and then the posterior inclined implant, the tilted one, in the tuberosity. And you see how they engage the bone, how I have utilized everything, all I had, all the bone, till the last little trabeculum. But this is what the no sinus lift concept is about. Prosthetics with angulated screw channels, with tilted screw channels, with angulated implant axis, no problem today for a good high-end lab, which I am proud to work with. So the before, the post-operative, and the bridge you see on the left side is installed on the right side. This is how I see today the no sinus lift concept, the restoration, and this is how I see my patients being cared for with the lowest level of trauma we can think of. And just to make the case complete, the lower, which is not my topic now, obviously, because I'm talking about the no sinus lift concept, was surgically done at the same spot, at the same time. One-stop shop, immediate implants. Let it heal, restore. Or this case, the whole old bridge started to move because those two teeth supporting it, the pillar teeth, were loosened in the bone due to infection, to periodontitis. And this is the full definition of the concept. A long narrow one, a short one, and a tilted one. Now that you know my handwriting, this is my way to do it. And I get so much feedback online from colleagues who every day direct message me on social media, on email, on wherever they can reach me, that thank you for the concept. I was very doubtful in the beginning, very skeptical. Now I'm happy I did it. My implant numbers are going through the roof, complications going down, I graft much less. So this is what I want to hear, and this is what makes me happy. And then the final restoration, or an advanced case. This case was discussed a lot on social media. Let's have a look. First, you would say, we need a sinus lift, easy thing, let's go. But then again, and this is my mantra, which I keep repeating, good diagnostics, 3D diagnostics in complex cases in the maxilla. You need 3D because without the 3D, you wouldn't see that the patient had a history in his past of infections, history of resections, of epicaptomies, of operations, of incisions, of so many doctors invading that, alveolar crest defects, permanent sinus wall defects. So this is not the case you want to drop into with a sinus lift, not knowing what was going on and not visualizing anatomy in a 3D way before you enter that. This is the infection. And then again, follow the path of the implants in the cross section. That's the frontal. And now you see how the implant goes in the middle. The video in the middle shows the distal implant in the tuberosity. And that's the path you want to have. Patient operated, patient healed, patient released back to the referring dentist to restore. Or even that, even more advanced. Difficult situation regarding anatomy. 3 implants placed. All were very high torque-wise, fixed in the bone, so that they in the end, as you can see in the central movie, had to be put into the final position with the manual torque wrench. And then again, the main actor today, the star of the show, the implant in the tuberosity. This is like a bore into the tunnel. I love to see how it engages, and you virtually can feel how it engages the bone and the stability you are achieving. Let it heal. The arrows show where the implants went. Let it heal. Analyze your success. And then again, the before picture, intraoperative, the after picture, the healing. And then comes the restoration. Patient happy because the patient has been told for many, many years by the dentists, leave those bad teeth even if pus is coming out, even if there is constant pain, mild to moderate pain, because once you lose them, no way you will ever have fixed teeth there. So the patient left those teeth way too long. And now he said, I should have done it according to that concept, following that treatment protocol so many years ago. I could have spared to myself so much pain and so much treatment time. And this is what we did. So as you can see, all these cases are different, but then again, they are not. It's the same consistent concept with short implants, or turn the concept around. No tuberosity, but a little bit of bone in the posterior. So a narrow implant at the mesial site, 2 short implants in the posterior. Splint them, and the overall surface of those 3 implants is much more than you think. So the overall surface engaging the bone, also integrating in the bone, is impressive. So, post-operative, few weeks of healing, restored, left. That's the patient at a recall after a few years. Works fine, and it's going to work fine for many, many more years to come. No bone recession, the bony papilla is still present, and that's it. The turning point for me with 6mm implants, because I have to admit I was really very critical and very skeptical with those short implants, was when that paper by Guillet came out 2014, which said that 6mm implants in the maxilla were equally successful as longer implants, which were compared with 11.5mm implants. And I even texted that guys who I partly know from the Benelux that I need the data for a longer follow-up. So then finally, 2019, they came forward with the same patient cohort, and they still had 100% success with the 6mm implants. And that's evidence which we need. That's the solid scientific ground, that's the columns we are standing on and which we need. And then we can expand the concept to semi-arch. Looking at this picture is like, oh, where did the bone go? Not enough bone. Really? Not enough bone? Combine the angulated, the tilted, combine the long ones, combine the short ones. Breaking it down to the point that if there is very limited bone, but you know how to use that bone and to use it to the max, then maybe you still can push it and save the patient from being forced to getting a sinus lift, grafting protocols and risky protocols. This is a semi-maxilla. It's 4 implants, precisely placed and combined in a 6-digit bridge. That's the bridge. Here we go. Angulated screw channels, so using the latest technology from the lab. Reposted by implantology team, big discussion on the net, and I got so much positive feedback about that and engaged with so many more doctors and specialists who I really respect all around the globe. Full conversions, the big case. Again, those big cases get so much attention on the internet. They are reposted endlessly and they get you into touch with so many colleagues. So patients like this are my everyday business. This is the bread and butter case, as we say here. This is the protracted perio case where the teeth cannot be saved anymore. Huge, tremendous, massive bone loss. But still, there is the bone, which is still here. It's not too much. There is no luxury abundance of bone, but still, there is bone. If you use it wisely, you can get the maximum out of it. 6 in the upper, 6 BLX in the lower, splinted bridges, use the tuberosity, full conversion, immediate implants. The whole implant therapy here is like, let's say 25 minutes per jaw, let it heal for 2 months, restore, and patients, they always say the same thing. I am so happy I did it. I wouldn't have expected it being so fast. I wouldn't have expected it being so affordable. And why didn't I do it like 10 years earlier? This is the constant things I get as a feedback from the patients. And then this is the biggest reward you can get. Happy patient, happy smile. Short implants are also for the full arch cases a nice weapon in your portfolio. This is a patient of mine. I placed her implants in the mandible 20 years ago. And then she came back for the maxilla and said, I am not going to be grafted. I am so afraid. Almost 80 years old. And then we were measuring the bone thoroughly. The new 6mm implants just came out. And we placed short 6mm implants, 6 of them. Look at how short the implants are compared to the impression copings, to the impression posts. And then again, restored, splinted, 6mm implants. The case was done like 3 years ago. Bone demanded, of course. It was done. The implants were placed where there was bone to place the implants. Restored, splinted, screw retained, and then analyzed the positioning of the implants in the bone, the integration, the covering, the positioning, and this is what we got, fixed. And a very happy lady who said, I should have done this many years before. Her, I could say no, because I couldn't have done it many years before, because those short implants with the tremendous surface and the tremendous technology and geometry didn't exist. But the first day they existed, we placed her implants, and she's more than satisfied and happy. So now, if you are a young doctor and you say, yeah, but I don't feel that safe placing the tuberosity implants freehand, I need more guidance, feel free to do it like this. I took this case from a young doctor, Anașescu, who does the same concept, navigate it. use digital technologies, use guided surgeries. With guided surgery, it's a different pair of shoes because reducing the diameter of your drills is a little bit more challenging. So guiding is a way to help you, a workaround, but guiding is not the total remedy. So you need to understand and you need to feel the bone and feel the implant functioning and working in the bone. And remember, less is more. What I'm telling you today is based on my full conviction and on my full belief that I've been doing it more than 20 years and tens of thousands of implants in thousands of cases in patients. And I fully believe it works because I do it every day and I see the patients recalled. I got so much feedback on the internet posting my cases that when one of the cases I showed you at the beginning of my lecture went viral on Instagram, a friend of mine called me and said, log out Insta, start it new, and you will see that on the starting page of Instagram, the algorithm in the middle of, wrestlers and martial art fighters and models and wild animals and, all the crazy stuff you find today in the internet, in the middle, there was my case. And I was like, okay, oh my God. So I seem to have stepped on some toes here and I seem to have started the discussion, and that discussion is getting viral. And that discussion is what led me today to be invited here and getting the privilege and the pleasure to sitting down, to formulating, to working on that concept and to presenting it. And so I want to wrap it up for you. The benefits of not sinus lifting are less trauma and pain, less complications, much lower costs, more patients, much less visits, so less chairside time, a more efficient and effective practice with a better workflow, more implant placed, and it's straightforward, much less grafting material, which is less risk of infecting it, which is less costs of buying it, easier getting a yes from the patient, because if you can get it to them with lower trauma, then they will be happy to adopt your concept and happy to say yes. I see it every day in my first consultations, patients coming in that I was told I need a sinus lift, and when I tell them I can do it without, they are like, really? Let's do it now, or let's do it tomorrow. And that's a big means and tool to convince a patient. It's easy to convince somebody of a therapy which is less painful, which is less risky, and which is cheaper. And in the end of the day, it's on the decision making. You need to understand anatomy. You need to visualize 3D imaging, the tuberosity, minimal bone height. You need to use the right implant. This is a very tough statement, but you cannot do it with every implant. And this is what I have to underline. Find what works in your hands and find what delivers the products, the results for your patients, which you are proud of. Under preparation, you need some surgical experience, which will grow by adopting the protocol, and then sprinted prosthetics. The key factors, again, my mantra: tuberosity implants, tilted, primary stability, which you need, immediate implantation, which is a must today, not only for the no sinus lift concept, but immediate implantation is a must. There is no implant practice without, and rest assured, patients get a second opinion today. When they come to see you as the first dentist, you are already number 5 after what they have learned in the internet. Regardless if it's right or wrong, but they have a certain point of view. And then they do doctor shopping, they see more dentists, and they will choose the one who can do it without grafting. By market research, this could not be more than true. One satisfied patient is going to deliver and refer a new patient. A disappointed patient with complications will tell everybody about the complications and the failure. So what you want is more successful cases on more patients placing more implants. That's where you want to go. So my statement, if I might allow myself a statement, is that the best sinus lift, even regardless that the sinus lift is an established protocol, the best sinus lift is the one we can avoid. I am about to close my presentation with maybe my favorite quote by Mr. Burwell, who was the Harvard dean at the time of the Second World War. And he said to his pupils on the first day that half of what we were teaching you is right and half is wrong. We simply do not know which half. And that sounds funny, but it's true. And if it might ring a bell, what he said is, keep asking questions, question everything. We constantly have to challenge our paradigms. Doing all the cases with sinus lift just because, oh, this is how we always did it, is not a reason anymore. This is not a reason to keep going with that risky and invasive protocol if you don't need it. So challenge that. Michelangelo said at the age of almost 90 years, I am still learning, and we are all still learning. I am very humble with that. I learn every day. I feel the implant, I feel the bone, I feel my patients, and what we want to deliver is a happy patient. So let's stay in touch. If you want to scan this, you get into contact with me on social media, on Instagram, wherever we meet on a live podium. I hope now that the world has slowly returned to sane and normal around the globe. I will be giving like 30 to 40 lectures next year all around the world. I'm happy to see you in the audience, in the internet, and wherever we can get in touch. Thank you so much. Hello, everybody. Thank you so much for the overwhelming number. We had more than 1,000 registered participants. This blew me away. Thank you so much that you find time to be part of my webinar in the middle of the day. What do we have? I have like a list of questions here. People from everywhere, from Doha, Qatar, from Singapore, from Germany, from Boston, from India. Hi, India. From Sweden. One of the questions are these implants pterygoid implants or tuberosity? This is an important question. These implants are in the tuberosity, in the tuber maxilla, anatomically, how we call it. The tuber maxilla is the most posterior part of the maxilla, which is still maxilla. And behind that starts the tuberosity. And the tuberosity is already the sphenoid bone. I try not to enter into the sphenoid. So I am in the tuberosity of the maxilla. I'm not in the pterygoid. So I stay in the tuberosity. What is the good brand for short implants? The short implants, which I used in all these cases, which is my favorite short implant, is not a specific short implant. It's simply the 6mm short version of my working horse, which is obviously the Straumann BLX implant. I think it's the most advanced product on the market, which is the combination of the craftsmanship from Basel, from Straumann, with the selective surface, with the positively aggressive dynamics and the geometry of the implant. Would the BLX changed the way we think today, changed the way we see implantology today? And I use the 6mm BLX for this, but I'm waiting for the 4mm TLX, which is somewhere in the universe and waiting for us. The next thing, hello from Qatar, hello to Qatar. In treatment planning, do you rely only on panoramic X-ray? No. CBCT? No. In these cases, I recommend strongly to take CBCTs, cone beams, which I routinely take in the cases when I want to place an implant there, to be very honest. I've placed roughly 45K implants. So I think I could perform most of these cases, especially it's not only the number of implants and the number of implant surgeries I did. I've been teaching human anatomy and dissecting for 16 years. So I sort of have a 3D visualization of the human anatomy of the tuberosity. I could perform, I would say, 70% of these cases without the cone beam, but the times we live in, all these forensic evidence times, you need to be also legally on the safe side. So I strongly recommend, and this is what I also do in my daily clinical practice, please do as much diagnostics as you need to be on a firm legal ground. Use cone beams. If you want, use 3D planning, all those tools, those smile in a box cases, or whatever navigation device you want to use it. Utilize the technology which we have and utilize everything what contributes to the safety, the predictability of your procedure. Because in the end of the day, the good surgery is going to provide for a happy patient. And a happy patient is the patient who is satisfied, doesn't give you trouble, and who will, and that's the most important thing, be happy over years with a predictable, successful treatment concept, and a patient who will reward you. And the reward is by good propaganda and by referring more and more patients.
The next question was, any research on the long-term 10, 15-year success rate on those long-span implant bridges with no sinus lift compared to those short-term implant bridges with sinus lift? I have been doing this concept for about 20 years. And the only thing I do is implants. So I did thousands of cases and I see those cases regularly. In a recall program, I see those cases, which are hundreds and hundreds of patients, maybe more than 1,000 patients or many thousands. I see them when they come in for the dental hygienic treatment, when they come in for routine x-rays, for routine panoramics after years, after 2 years, 4 years, 10 years, 15 years. Those implants hardly ever fail. And coming back to your question about the fracture of bridges, they do not fracture. Today's bridges, what I use is I do not cement anymore, hardly ever. What I do is only screw retained, and this is something you don't want to hear, without multi-units. They are screwed on implant level. Tilted, angulated screw channels, tilted implants, screwed with strong screws directly with the vario-based screw, where the screw is like this and the screwdriver is like this, screwed directly on the implant with no mesostructure in between. That guarantees for superb fit, for precise fit, for no loosening of the bridges. And my bridges are milled, and I strongly believe that those milled bridges are super strong, and I haven't seen one single fracture of the milled bridge frameworks. I haven't seen fractures of the screws. The only fracture happens when there is a screw loosening, and the loose screw, and the patient doesn't come in with the loose screw. So whenever I see a patient who comes in and says, look, it's fractured, I'm like, how long was it mobile? And they, yeah, a couple of months. So I'm like, you are driving your car for another 200 miles when the screws are loose on the tires, or you stop and tighten, or you get somebody to do it for you. I would stop immediately. I mean, yeah, please. And this is the same thing going on here. If something is loose, it's not meant to be loaded anymore. But with modern screws today, I see no screw loosenings anymore, hardly ever. The next thing, hello from Costa Rica, beautiful country. I've been there, the most beautiful nature I've ever seen. I will never forget the jungle, and I will be back. Sicily, amazing hot holidays. I can remember that. Is it not bad when you put the implant with 80 Newton? No, it's not. Thank you especially for this question. I have lost implants which were not strong enough in the bone in terms of primary stability. I have not lost one single implant which was in the bone too strong. I certainly exceed those 80 Newton centimeters by far in many, many cases every day. I do not believe in compression necrosis of the bone, especially not in the soft maxilla, but I strongly believe in initial primary stability. Put in the implant, let it heal. You don't have to load it immediately, but trust the implant and enjoy and appreciate stabilities around 80 Newtons. I want to repeat myself, I exceed those 80s in many, many cases. So would you use implants a little wider than the extraction socket? Is enough apical bone to the extraction tooth be critical too? We use implants now as wide as we can, but still reduced diameter implants for immediate implants. You don't want to compress the buccal wall, otherwise it's going to resorb. The thing is completely different in a healed part, in a healed area of the maxilla or the mandible, wherever you work. Especially tuberosity is always healed because there was no bone. Sometimes I even remove a wisdom tooth to place a tuberosity implant right there. But yes, I go as wide as I can, but still you want some remaining bone around the implant, like let's say 2 millimeters. The tuberosity is softer than the rest, especially postmenopausal, especially in older patients. So the trick, and this is now maybe the most important take-home message, what you want to do. The trick to get primary stability and get the implant in, it's not that easy. I get calls and mails from colleagues who say, I started putting on the implant and then, but listen closely to this. Then the implant stopped getting into the bone, started rotating, and I could not get primary stability. I'm like, yeah, I know, you're not listening. We under prepare, but here it comes with exclamation marks. We under prepare the width, the diameter of the preparation. We do not under prepare the length of the preparation. Otherwise, in that soft bone with the tip of the implant, which is not very pointed, it's quite flat, you compress the bone upwards till the force, the resistance of the bone vertically in direction of the implant insertion exceeds the hardness of the bone in the lateral. So the implant stops halfway, 2/3 way in, rotates and becomes a bone mill, to exaggerate a bit. So you want to make sure that you exceed the length of the implant, even like a millimeter intrusion into the sinus in like a bicortical fixation. You don't want to intrude too much into the sinus, but like a millimeter is nothing. And when you over drilled vertically, then you stop drilling. And then comes the implant. The bone can evade to the side. You do not compress it vertically, but you get a superb primary stability, and you make it all the way in. You get the primary stability and an insertion torque, which you need into tuberosity. And then you stop, you leave it alone, you let it heal. Always put a healing abutment. There is no reason to get a second stage surgery, except in very low stabilities, when you're afraid that the total prosthesis, which you maybe want to use sometimes for the healing time as a provisional, as the transition, then maybe you are afraid the prosthesis is going to put too much force on the implant and you might overload it before it gets perfectly integrated. Then you want in the soft areas to place a flat cover screw and close the wound. Otherwise, you don't want to do that. You want to place a healing abutment, let it heal primary, and that's the best thing you can do. Why 3 implants? Is it necessary, the tuberosity one? You need, and there is no clear answer to this. If you have seen the webinar right now, the lecture, I showed many cases with 2 implants. You don't have to do 2 or 3. Sometimes I do 4 or 5. Sometimes I do 2. I would say in most of the cases, it's limited to 2 implants because that's enough. But what you need is to consider the overall situation, the bone quality, the bone quantity. The quantity means you need a certain length of implant in the bone. Like 2 implants, you add the length. 3 implants, it's much more length. And then consider one thing. If you have a bridge with connected 3 implants, and one of the implants fails after a couple of years, and you have to remove the implant, what do you do? If it's 2 implants, you lose the bridge. Failure in the eyes of the patients. If you get 3 implants, you remove one of these, you reattach, you reinsert and rescrew your bridge. Nothing changed for the patient, and there is another more years to go. And sometimes it's enough, and it goes on for many more years to come. So one more implant, it gives you more security, more predictability, more safety, more loadability of the whole thing, because there is Mr. Newton, and in the end of all discussions, Mr. Newton is right. It's Mr. Einstein and Mr. Newton. They are right. They are those two who I believe. So that's physics. It's loading. It's the extension. It's the span of the bridge. It's the occlusal force. It's the antagonists in the other jaw. So you have to consider many factors. So there is no right and wrong answer to this question. There is no ideal number of implants. And don't forget that to spare the patient the sinus lift with this concept, a lot of pain, a lot of treatment time, sessions, foreign bodies, and you save the patient the costs of the sinus lift. So I think that one more implant is cheaper than what the sinus lift would have cost. So it cannot be a cost issue here if it's for the best of the patient. The next question. Thank you for the presentation. Do we have a long-term radiograph? It looks that the patient won't be able to clean around the tuberosity implant in some cases. Cleaning is not a big issue. We, of course, train the patients how to clean. It's not rocket science. They clean with electric toothbrushes. We get them back after a few weeks for the first dental hygienic session to see if there is a spot which the patient doesn't notice, if there's a spot where the patient does not clean a niche. Sometimes we alter a little bit the shape of the bridge. With very narrow ridges, we sometimes have to face the shape of the ceramic teeth, which are, bulky to get to the original size. So the size of the tooth is right, but above the bridge, the ridge of the maxilla has become narrow. So that makes for a niche. That's why after a few weeks, I'm obliged, I'm forced to, to prep a bit the ceramics, and instead of this, to prevent the balcony, I flatten it a bit and make it smoother. And then the patient says, "Ah, that's a miracle. Hardly any more food getting stuck there." So yes, you have to get the patient back to recall him and see how your beautiful dental work works in everyday usage. That's of course very, very important. And we do have, of course, long-term radiographs. At least every second year, we take a panoramic. Isn't the crown over the tuberosity, that's the next question, tilted implant too much posterior? It seems that there's no occluding surface in the mandible against it. Also, is the posterior side cleanable by the patient? More or less the same question. Yes, of course, you're right. You observed it correctly. Sometimes we have more crowns due to the posterior implant in the tuberosity, we have more crowns in the upper than facing teeth in the lower. That's not an issue, because just because it doesn't have occlusal function, it has mechanical function because it connects the whole thing. But what we do sometimes to save the patient money is that we either don't charge for the last crown, or, and that's a nice trick, cheap trick, the last crown isn't made a crown. It stops at, let's say, the second molar, and instead of having the third molar, the last crown is just, a little connection which accepts the screw, and it's not made a ceramic crown. So the patient isn't charged for one more crown. But because the last implant is there, this is where I need to attach, and this is my docking side. That's what it is. Long-term survival supported by short and tilted implants. How about this concept in soft bone? Thanks and regards. The question from Korea. Hello to Korea. The long-term survival of implants today is way above 98%. Believe me, I wouldn't have placed so many implants if not the vast majority of my patients wouldn't have been referred by satisfied, happy customers of mine. So there's one thing I cannot afford, same thing you guys out there, my friends, cannot afford, is unhappy patients and failures. One failure is driving away dozens of patients of your practice. One success is going to bring a few more patients who come in for consultations, and if you do the job right, they will keep on getting the therapy in the first place and becoming new referring dentists. So I would never use or recommend a concept which doesn't give me perfect support for my practice, also for my business concept. Things which don't work are the biggest enemy. That's why I don't do that. I stopped doing things which didn't prove perfectly functional and perfectly predictable in my practice. I stopped it. This is a big private practice, and it's not a big university anymore where I have been working for more than 20 years. And a private practice is just a little private practice. There you're alone, and there you do your job, and you gotta stand your man, stand your woman, and be relying on your skills and the success of your therapy. So in soft bone, I think that the splinting of many implants in the soft bone gives the soft bone more stability, gives the implants more stability in the soft bone. Don't go for, don't collect all those culprits. Soft bone, short implants, single tooth restoration, don't do that. Do more implants, place more implants, and connect them. Believe me, the connecting of the implants gives you rotational stability, loading resistance, long-term survival, and more function, more success to your practice. Would this concept work if still one upper molar remaining on the way, but the rest of teeth missing with canine missing as well? Absolutely, absolutely. With one upper molar remaining, the concept is not even a terminal thing in the maxilla. I save all the teeth I can save. If you have a canine, good. The canine is maybe the most valuable tooth we have in the human jaw. The canine is a tremendous tooth with a long and strong root. If I can save a canine, it's good. I can save most of the canines and I lose most of the periodontally affected and damaged premolars. But again, the premolars are fine places for immediate implants, especially the first premolar where the sinus cavity is still way up and it gives you some length and some bone to attach that. Do you use surgical guides for placing implants? Hardly ever. I'm a gap generation. This is an open wound of mine. I'm a digital immigrant. I was born 1970, which makes me 52 at the end of the year. I can't believe it. I can't believe it. I didn't grow up with computers. I didn't grow up with iPhones like everybody in my generation. I learned through this to do the things manually. I do freehand surgery 99% of the cases, but I did lots of navigations with different systems out there. They are good, and especially the younger generation, they grew up with this. So digital planning, guided surgery, go for it. It's something good. But the guided placement of implants gives you less control. So I think that, it's the old days when the chess champions said, Kasparov and Karpov said, no computer can beat me in the chess game. And it was like this, and everybody would have bet nobody can beat those guys in chess. Now, the computer called Big Blue, the IBM computer, it beat both of them, I think. So humans' capacity as ruling everything is, human reign is over, and we have to fight for our skills. But still, I bet that the bone handling, freehand, I feel the bone with my freehanded surgery better than through the navigation device, than through the stance, through the navigation guides. Because then more or less you have to follow the protocol. And if the bone is softer than you think, it's more difficult. You cannot over drill the way you want. It's if you under prepare because the bone is soft, hard to manage the insertion. But I'm sure that in 5 years, 10 years, 15 years, there will be the full digital protocols. We are dreaming about them. We are preaching about them. We are not there yet. So full digital is, it's knocking at the door, but it's not in yet. Now, taking into consideration my age of 50, hopefully I stay healthy and I will be doing implants for the next 15 to 20 years, maybe longer. My dad, who is going to be 80 in 2 years, is one of the most skilled, still practicing the implant prosthodontist ever, and I learned so much from him. But we will see if I can practice till 80. That's at least the plan and the dream and the things I will have to and I will love to. But I will be forced to go more digital. That's why of course, we work with a 3Shape scanner. That's why I am I'm working with real-time navigation systems, but I don't want to get too much into it. But to make the long story short, if you can navigate it, do it. Because just the planning phase of it gives you so much training, and you learn so much about the visualization of the 3D situation that you want to do that. Next question. In immediate extraction cases, do we graft to cover the jumping distance along with the BLX? That's a difficult question. I have not been grafting that for many, many years. I started grafting those gaps lately just to prevent atrophy, to give it a bit more bulk in the aesthetic sites. Otherwise, I don't do it. When I do it, I use the Straumann Sinoflex from the injector, because it's very easy to handle and there is no complication with that. I made like hundreds of successful cases with that. I don't think you have to graft all the cases, but if you are more a grafter, do grafting. But bear in mind, the more foreign bodies you use, the more you are in danger of complications of, all those things going on, like membrane expositions. I try to reduce it to the max as much as I can. Do you use guide in all your cases? No, I have answered this. I hardly ever use it. Still, guiding is good. And if you're good with guiding and planning, go for it. Suggestions for accessing guided implant placement in the tuberosity area. I don't really understand this question. Um, if you, my suggestion is try to get as much bone contact as you can, the longest path through the bone, and don't care too much about the inclination, because today with angulated screw channels, we can correct for a lot of it. Many of your patients shown here had severe periodontitis, and after that, you insert short tilted narrow implants in the posterior. Are you not worried about the peri-implantitis and late implant loss? Thank you for this question. Very, very good question. Dr. Kimmo Wahalo, based on the name, I think we are up in the north in Finland or somewhere else in Northern Europe. Beautiful. A legitimate question, a question which makes sense, a logical question. No, I'm not worried. Periodontitis, the definition of periodontitis is the infection of the structures around the tooth, around the root. If there is no root, there is no periodontium. If there is no periodontium, there's no periodontitis. Still, we do have peri-implantitis, of course, which is totally different. If I have bone, I don't care about periodontitis. Of course, I thoroughly, diligently take time to reduce, to remove those infected soft tissue areas, the pockets, you know, all those inflammation, the debris, whatever there is. I locally disinfect it. I don't know if it came through in those lecture. Short before I gave the lecture, it was very long, like all my lectures, and I had to reduce it. So I took that part out, the disinfection of the socket, the managing of the socket. I use chlorhexidine. I use betadine. Betadine, if the patient is not allergic to iodine and the patient has no hyperthyroidism, like an overfunction of the thyroid gland, I routinely use betadine to disinfect. The betadine kills everything. It needs like 90 seconds, 90, to work on the soft tissues. I constantly reuse, reinsert, re-rinse, and then I insert the implant. Sometimes, while the implant is rotating and moving in, my assistant drips on the implant the iodine. Remember, this is a take-home message. So the implant takes it in all the way into the depth of the bone. And that makes for another disinfection. And I don't see those problems. Otherwise, again, I wouldn't do it, because what I want is predictability, success, happy patients. That's the pillar of the practice. Impressive. Merci beaucoup. Thank you so much to France. Gracias. Thank you to Spain, or all those Spanish, the whole Spanish speaking world. Thanks for a great lecture. To Hungary, thank you so much. To Japan. Where can I read more and learn about your protocol? I'm happy to be very approachable, reachable. I love the discussion and the exchange with all my esteemed colleagues out there, especially those who sacrifice their afternoon, early evening to spend time with me. Thank you so much for being here, and thank you for remaining with me. Easiest thing is to follow me on Instagram. It's free, of course, and see the cases. I've posted hundreds of cases. I'm a late starter with Instagram, of course. My whole account is like 1.5 or 2 years old, but still I do my best and I show so much and I engage in discussions there. So Insta is simple, and you can reach me on Insta with direct messaging or open discussion whenever you want. Thank you for sharing, for expertise. Of course, Melinda, my pleasure, my privilege you're here. What would be your selection criteria for patients with the no sinus lift concept? Are smokers responding well to this treatment modality? This question, Mr. Ying Chang, Vincent Chan. Smoking is an issue, and we don't live in a fair world. If there is sufficient bone, I hope patients that don't hear that. If there is sufficient bone, smoking is not that a big problem. Smoking is not that a big problem in men. It's not fair, I know, but medicine is not about gendering. Smoking is very unfair and gives big damage to that part of humanity which today sadly smokes the most. And in my experience, I don't have numbers and statistics, women today smoke more than men. That's what I see. I hardly see older smoking men. maybe because men are weaker, and men who have been smoking all their life for tens of years, for decades, have to stop one day because their cardiologist tells them at 60, 65, stop smoking or you'll die. So I don't see those 70, 75, 80, 90-year-old smoking men. Women, on the other hand, are fitter, are tougher, are healthier, are petite, are tiny. And women, of course, women suffer from those women's diseases, but men have something what kills them. That's the testosterone, and testo kills the heart. And men have to stop smoking earlier. Women can smoke longer because cardially and with the lungs, in most of the, like in the overwhelming number of cases of patients I have encountered, women can take smoking much better, much longer regarding their health, their lungs, their heart, whatever, but not regarding their bone. So the combination of being a woman, like having less bone, obviously, being tinier, being smaller, the anatomical sizes, the menopause, the hormonal changes, which we know are terrible for the trabecular bone pattern factor, for bone trabecular connectivity, for osseointegration. Women get those medications like Prolia, bisphosphonates, Bonviva, Prolia, Aclasta, Zometa, whatever they are. They might be good against to prevent fractures of the spines, of the vertebrae, of the hip. Of course, they are valuable. We are grateful having them. But on the other hand, they are terrible for the jaw. And all those factors, and then comes your question about smoking, makes a big difference. Smoking women have less success with implants, show much less success and predictability. Once the implants healed in, it's sort of okay for a long time to go. But those early failures in the osseointegration phase when healing in, they are much more likely to happen in women. Again, I do not have statistics, but I have a dental practice and I try to get the best results for my patients. And then again, there are no men alive in that age range above 85 and more who want implant in those numbers as healthy women way above 90. That's when demographics, shift. That's what it is. That's not fair again, but that's life. Which implant system do you recommend? I have used a couple of systems. When it comes to challenging situations, I want the S-selective surface and I want the BLX implant. For the primary stability, for the predictability, the FDA has recommended the implants that S-selective surface, hardly everybody knows, for radiated bone in diabetic patients. And this is what I rely on the FDA recommendations. And I do most of my cases today with the BLX implant. I placed about, I would say 12 to 15,000 BLX implants in the last 5 years. I had the privilege to be one of the first to use them. And so I look back at 5 years at the end of this year of success rates with the BLX. Thank you for sharing for expertise. My pleasure. Then what would be my selection criteria for the no sinus lift concept? If I can take the responsibility to place implants so that these implants so that there is sufficient bone to get like an overall added implant length of my 2, 3, 4 implants, then I go for that. Whenever I feel, based on those years and hundreds of cases I did, that predictably I can place the implant without sinus lift and spare the patient the sinus lift, I do it. Again, I'm not against sinus lifting. I did hundreds or thousands of sinus lifts for many years, still doing them, but I do much less than I did because I ask myself in every single case for every single patient, does this lady or gentleman really need to go through that or not? Then thank you very much for giving me a whole new philosophy. My pleasure. Thank you so much. Dr. Steve Harrison, thank you for being here. Then which implant system would you recommend? Again, Dr. Franz Palkovic. Again, as I said, at the moment I'm using the Straumann BLX and I don't think I'm gonna use something else for these challenging cases anytime soon. With all the different angulations, any problems with fitting of the splinted prosthesis from Anonymous, No, but you have to reduce, of course, the insertion length, and you need a very, very good lab. It makes no sense to use some cheap implant from the internet, but it makes no sense to save on the pros. You need to work with the best dental lab technicians. The most expensive thing you can do is working with a cheap lab. You don't want to do that. You don't want to have the complications, the non-fitting, the hours and hours of redoing, of patient complaints. There is one thing which I learned by my teachers when I did my postgraduate year at UCLA in California, and they said, "Do it right the first time." And this is the sentence which is my slogan: "Do it right the first time." I try to do it right the first time, and I work with the best lab technicians I can get hold of. So it's precision milled. It's as digital as can be. It's angulated implants. It's tilted screw channels. It's not cemented as whenever I can. It's screw retained. It's passive fit. There is a recall system. There is X-ray controls of the post insertion of the pros. I make sure the whole thing fits. You want the best lab technician you can get. I hardly ever have insertion problems. I don't see that. Um, what about the pterygoid implants? How are they different from tuberosity implants? Um, the pterygoid implants would be much longer going into the pterygoid process of the sphenoid bone. I don't think we need that. I think that there is a problem of the nomenclature, of the naming, that many people say pterygoid implants, but what they mean is tuberosity. So be sure, go back to your anatomy textbooks, get a human skull, get a model, go into the internet, and look at the anatomy. What we talk about is tuberosity. Hardly ever it's the pterygoid. What's the minimum and maximum angle you can tilt a pterygoid implant? I have not measured that. I mean, the flatter you go, the more divergent you go from the anterior implants, the more difficult it's going to be for prosthetics. So as steep as you can, but I'm sometimes, like this. So I would say 30, 35 degrees or even more, uh, maybe 45. Try it, push the envelope, go for it. The worst thing which can happen to you is that the lab cannot perform the screw retained thing all the way back, so that one of the implants needs an abutment for made to measure to correct that, and that you cement the posterior. It's not ideal, but it's a step and on the way getting there. Does the tilt concept always need a CBCT scan to avoid sinus, or are there any techniques? I would recommend to get as much information beforehand, before the surgery, as much as you can. You want to know where you are. You want to see where you are. You want to visualize three-dimensionally where you are. If you do it, maybe even if you don't want to guide, it helps for training purposes to utilize a guiding, planning software to see what to expect, how far you can go, what's going to be, the predicted length of the implant, the diameter. Even if there are surprises during surgery, more or less you rehearsed it already. So depending and standing, on the column of your experience of placing implants, whatsoever, you need more or less planning. And you will see, and you will think and remember my words. This is a steep learning curve, which you will encounter, and you will love the system. Give it a try, give it a chance. Does the tilt concept, we had it, criteria for pterygoid implant? It's not a pterygoid, it's as we said, an angulated implant in the maxillary tuberosity. How much under preparation is needed? By Dr. Schieferbachis, as much as you can get. You need a sort of minimal preparation. Sometimes, in most of the cases, I just use the first drill, 2.2 millimeters, sometimes the 2.8. But in the soft tuberosity, I stop. What I do is, I try to explain it to you. This is the narrow implant, the narrow drill, let's say the 2.8. I drill, and still rotating, I go like, the tip of the drill where it is, And like I make it a bit conical, and then I take it out. And then comes the implant. Let's say for a 5 mm implant, in a soft bone, I stop with the 2.2, but go long enough. The softer the bone, the more you have to make sure, as we said like 20 minutes ago, that you are protruding, that you are going in there. With a short implant in the anterior region and one in the tuberosity, what would be the biomechanical challenge, especially when there are 2 or 3 pontings? Passive fit and a good osseointegration of your implants. That's what it is. You don't need more than that. What's the protocol for immediate placement after extracting an infected tooth? And which Straumann implant do you use for this type of procedure and for the 6 mm ones? Dr. Laurent Riva. The protocol is cleaning by drilling. Remove the root. You can clean it mechanically, scratch it, clean it. And then, the drilling itself is a cleaning. Bleeding cleans, bleeding flushes everything out. Then I use, as I said before, iodine, if I can use it medical with the patient. And then here comes the implant. That's all. Congratulations for the excellent presentation. How about the insertion torque with BLX? How many newtons can LockSim support? Here it comes. You got to be strong now. There is no LockSim with the BLX. Thank you to Straumann. We don't need the LockSims anymore. I strongly feel that we will lose the LockSims on the way from all the systems. They are precise, they are expensive, but it's like wearing a belt and the for the pants. It's too much. The implant will never break. And the BLX implant, especially the wider ones, they are so tremendously strong, you cannot break it. Believe me, I tried it. I broke the insertion pin. I broke the torque wrench many times. I never broke these implants. And that's good. And I didn't even damage the torque fix, the torques, the prosthetic connection. You don't break it. You break different systems. I broke many implants. I haven't broken the BLX, and I won't. It's impossible to break them in the bone. And you want torque, you want primary stability. No LockSim needed, no LockSim existing. Hello from Albania. Thank you for joining. Thank you for the lesson. I really love short implants too. Good, so we agree. Thank you, Dr. Alba. Can the concept also be used without a tube implant? Absolutely. I sometimes place like a couple of short implants, 2, 3, 4 short implants, splint them. An implant is not a tooth. An implant is not a root. I strongly believe we don't need to restore them as single teeth. If there is no aesthetic reason, like in the front, I splint them to have bridges. Then, good afternoon from Greece. Thank you for a very nice presentation. I wanted to ask you, how do you measure the quantity of the bone in tuberosity, and what do you do in the mandible? You see the quantity. You see it in the cone beam, and I measure it in the cone beam. There is a measuring software. It's click with the mouse, and it's measured, and then I know the length to not to intrude too much into the sinus, not to injure the nerve. It's the mandible, and whenever there is close vicinity to structures, then you don't want to do that. You want to be on the safe side. Cone beam CT. That's how I use it. Thank you, doctor, for a wonderful lecture. Thank you so much. My pleasure. Is there any limitation in the angulation of implant placed in the tuberosity? If there is no tuberosity, if you cannot get stability, if the tuberosity is not existing, and many people don't have a tuberosity, so you need an anatomical assessment beforehand to know if there is one, if there is bone to place it. Do you condense the bone, as it's usually type 4 in these areas? I condense them by under-preparing. I condense them by not removing. I condense them by using a narrow drill and a wide implant. That's my condensing. Hello from California. Wonderful lecture. Thank you for showing new concepts. Do you see a challenge for the patient to reach that far back where the tilted implant is to maintain good plaque control? It's about the work of the lab, of course. It's about the construction. It's about creating or avoiding niches which collect, food that you don't want. So you don't want those bulky round teeth. You don't want those balconies. Above them, you have those little tiny pockets. And especially in the US, I'm not worried because you are super hooked on oral hygiene. You got the best dental hygienists in the whole world. It's a whole profession, the dental hygienist, the whole specialty, and it's good to have them because a big part of our success relies on the dental hygienist, who's an amazing person in the practice and tremendous quality of service they give to the patients. We need them. The difficult thing is to encourage the patient to come back constantly to see the dental hygienist because they teach. It's very responsible what they do. They teach them how to clean. Again, first it's the placing of the implant, then it's the dental lab technician planning and manufacturing. It's a piece of art. All those implant bridges exist one time in the world. It's like a piece of jewelry made once. It's that one bridge for that one person in that one place, in that one mouth on that side. So that's how I explain it to the patient. It's a piece of jewel. Do you recommend the use of multi-units? No, I don't. I don't like them. They are good. The only reason they are good, they are utilized is they correct triangulations. They are used to communicate easily between the surgeon and the prosthodontist, make their lives easier. But don't forget that the multi-unit is fixed on the implant with a strong superb screw, and then the pros itself, the bridge, is fixed on the multi-unit with a tiny little nothing. I don't like them, but they are good. They're good. Use them if you like them. Try without. Restore on implant level. It's a bit trickier in the beginning, but it's so rewarding. It's one micro gap instead of two. It's amazing. I do not use them. Do you prefer restoring to implant level or to multi-unit abutment? I think I answered it, Dr. Jason Larkin. I'm very clear with this implant level. Thank you for your presentation. Most of the cases, free implants. For the cases with terminal edentation, last tooth 14, which is the first premolar. If we use one tilted in the tuberosity and one in the premolar because we cannot go longer, does it resist? Also, is not too long the Pontic? I don't think it's too long. If there's, let's say, an 8 or 10 millimeter implant at the premolar, and if there is a nice angulated implant, tilted implant in the posterior, it works. It's my daily piece of bread. I think it's good. If the tooth is infected, placed immediate implant will affect the success of the case. No, there is literature, abundant literature. For example, by the amazing group of Anne Benneberg from Malmö in Sweden, Kokranovic, who have proven that the success rate of placing implants in the infected or contaminated socket is good to place implants. There is a paper by Malo with over 99% of success rate for immediate implants, which are immediately loaded in the perio case, which is not even treated before that periodontally. I strongly believe in clean surgery. Remove the reason for periodontitis, which is the infected root, clean it, and then the bone will say thank you because the bone has suffered long enough. Hello from Lebanon. Hello to the Middle East. How much do you under-prepare your implant site in the tuberosity? Implant for 0, you prepare 2, 4, or 3. Dr. Tulik Boutros. Hi to Beirut. You cannot tell it that exactly for every implant because it's, of course, obviously, based on the bone quality. The softer the bone, the less you prepare. Sometimes I even use just the 2.2 or 2.8. Again, intrude long enough, but not wide. And then I go for a wide 5 millimeter implant sometimes. Implant with cantilevers, your opinion. I don't think they cause problems. If there's a passive fit of a strong, milled, precise pros, I don't think that will be a problem. Of course, you cannot cantilever, like a mile, but one molar, all those concepts like Olin 4, all those Olin 6, they do that. And I'm not afraid of cantilevers if the quality of the pros is good and the osseointegration is good. What type of prosthetic rehabilitation do you prefer? Depends on the case. I prefer screw retained fixed rehabilitations or the classic good old removable on a bar. The bar is problematic only in terms of hygiene. You train the patient, you teach him how to clean, but the splinting, I'm a splinter. Our prosthodontist splint. So I don't think that splinting is a problem. I think it's good. If removable, then on a bar. If fixed, then screw retained. And if you can avoid it, forget cementing. Good. Where can we learn the basic implantology in a good way? Anonymous. I don't know where you are at home. Follow the leading companies in the market. Follow the companies which give you trainings like today. They know where you can go locally, or you even come and find somebody who you think worth going and visiting. You are welcome in my practice. Straumann has all the contacts. Come to see me in Vienna, Austria, one of the most beautiful cities in the world. So whenever you want, come, call Straumann, call your local rep who knows where and when the courses are. It's one-on-one training courses. I'm happy to host you. Then, if you have 4 millimeter vertical, do you perform a Summers technique? Very, very rarely. Summers technique it's sobering. Coming back after years, you cannot gain a lot. You gain like a millimeter. It's I don't think that summer works vertically a lot, maybe a millimeter. To the lateral, you can do that, but to the lateral, you don't need that because the lateral you under prepare and you get the same thing. How long do you wait in the case of very soft tuberosity bone for the implant to integrate from an animus? 3 months till loading is the minimum I wait for that, but you don't need to wait longer than that. Thank you, Prof. Gabor. Amazing lecture, amazing concept, amazing cases. Thank you so much. The practical knowledge. Thank you again. Dr. Falima Kapazi, wherever you are, my privilege. Thank you so much. It humbles me. It's my honor. It's the reason I get up in the morning, and it's the reason I share. And I'm one of those teachers getting more and more compared to the older generation who didn't want you to learn in many cases, who just wanted to be admired. Some of them, not all of them. I think our generation is happy and proud to share, and we want to give you a take-home message. We want to give you a value, and if you got a value, my pleasure. It's not competition out there. It's colleagues, and it's going the way together. There are so many patients out there. There is so many gaps out there. There is so many teeth out there to be replaced. It's up to you, and nobody takes away your implants. You take from nobody. It's our success, and we can go the way we can go walk together without envy and jealousy. How does this concept affect the crown to implant length ratio in cases of severe resorption? Of course, smart question. The longer the crown's got to be, the more implants you need if the bone is short. If there is not sufficient, not the abundance of bone, go for 1 or 2 more implants. Explain it to the patient. Tell him it's not about the costs, it's about stability, predictability, and a long time survival. How does the concept affect it? Yeah, we did that. Do you get a lot of morsication problems in the bucca? No, we don't get that. Sometimes patient gets irritated in the beginning, and then we know, remove it, smoothen it, flatten it all the way back. Sometimes, even as mentioned before, it's a really very good practical question here. Thank you for that. We remove the last crown, especially if it's not antagonizing. Then we remove it, and there is just a narrow, nice little, guidance into the implant, and then the irritation stops immediately. But that shows how practical you are, and that you have treated so many patients already. Otherwise, you wouldn't have thought of that question. Thank you for this. It's proof of your, all the miles you made already in implantology. Do you get what's the Insta name? The Insta name. Thank you for following. I would love to be connected with you in Instagram. My Insta name is look up my name, Gabor.Tepper. Gabor. It's like Jaja Gabor. Remember the former actress. It's GABOR.TEPPER. It's Gabor Tepper, and you will find me on Insta immediately. Can the protocol be applied to different Straumann implants? Of course. If you feel safer with the BLT, go for the BLT. And then the TLX is the new smartest guy in the room. Give the TLX a chance. Superb combination of an implant going all the way all the way through the bone, no micro gap at all, going all the way. It's a one-piece implant all the way through the soft tissue, and then you go on implant surface, on the implant level. The TLX is an amazing implant based on the old tissue level implant. Thanks from Pittston, Pennsylvania, USA. Thank you so much. I will be in the USA a couple of times this year. So just look up the program. I'm traveling worldwide and lecturing a lot of Europe coming up, a lot of Germany. So let's stay in touch and see what I'm doing. Summers lift concept. I don't do that much summers lifting because I don't see the benefit of that. Hi, everyone. Hi, back. Sir, does the diameter matter in the case of short implants for the maxilla? Dr. Vickersteep, yes, of course, the diameter. The diameter compensates for the length. So if it's very short, then you want to get diameter because diameter means surface. Surface, especially the superb roughness of the S-selective Straumann surface gives you bone to implant contact. And bone to implant contact gives stability. So if you can go wider, of course, go wider. Thank you so much. Best regards from Norway. Katja Franke, thank you. My pleasure having you here. Thank you. Amazing webinar. Dr. Hamad Reza Shirazi, thank you. Amazing lecture. Thank you, Doctor from Anonymous. Whoever you are, my pleasure. It's always a pleasure for your lectures. Professor, thanks for this great lecture and for sharing. Dr. Manuel Mamasadi, thank you. I assume to Iran, obviously. Greetings from Toronto, Canada. Beautiful Canada. I love Canada. It gave me a second birthday. I survived an avalanche in British Columbia in 2007. Thank you, Canada. Thank you very much for Doctor for sharing your wisdom from India. India is one of the places I would love to visit, and one of my best friends gives tours in India in meditation, goes to the north, goes to the south, to the Himalaya. So India is on my bucket list, and I'm sure I will be there anytime soon. This looks to be the last question. What an amazing, amazing Q&A. This is what I work for. Thank you so much. My pleasure. I see you on Instagram. Thank you. Goodbye from Vienna, Austria.